we can't able to bring down the HbA1c levels to the target levels and modify the metabolic obesity. Always the weight loss not only helps for the remission, it also helps us to bring down the drugs count. It also bring down the insulin resistance. Definitely we can able to achieve a good glycemic control if we address metabolic obesity. And always manage microbial infections, stress, dehydration and depression also. So whenever in clinical examination we have to look for any foci of infection, stress, depression and dehydration. All these things to be addressed and re-examine the diabetes treatment protocol. Just because you are given, this is not the right management. Many times we have to re-examine whatever the diet protocol we have given. Can we continue the same or re-modify the drug? And the last one, guide the patient as per guidelines and recommendation. Always keep in mind, we should have a pharmacokinetics and pharmacodynamics in our back in mind and patient preferences, choose a drug accordingly. Thank you for your patient listening, and we are going to have Tamil Nadu chapter RSSD annual conference. We are having our national all India EC member here, Dr. Shanmugam sir. Welcome sir. So we are going to have a track conference in September 28 and 29. I request kindly join with us for the very good academic feast. As per the DCCon, the next feast we are going to happen in September Vadapalani. We are having discounted rate registration for us. 50% discount registration is happening. We have you can scan the QR code here, you can register, or we can have a standee outside. The same way you can scan the QR code and you register for the conference. Thank you for the opportunity, sir. Thank you, sir.
Thank you, sir, for the insightful speech. The audience has any questions for sir? Yes, ma'am.
Affects the glycemic level, sir.
Definitely, madam. Dehydration will have an insulin resistance, particularly if a patient having insulin injection technique. If a patient having dehydration, whatever the insulin we inject subcutaneously will not be get absorbed, sometimes erratically get absorbed. And dehydration, not only in insulin technique patients, dehydration will, the natural way of diabetes management is pushing the glucose via the urine. If a patient already on SGLT inhibitors, dehydration will not work better, so the patient will have a hyperglycemia. And whatever the insulin, even to insulin to work, patient should have a good hydration to the insulin receptor levels. So dehydration not only works for insulin, also for SGLT inhibitors, and whatever OHA you do use, dehydration alters the insulin response.
Sir, congratulations, wonderful presentation and really a professorial talk highlighting your own the protocol, this clinical protocol based on the experience and guideline. You have wonderful information you have learned. And most of the time we face a case like, patient who is taking steroid, high dose steroid for rheumatoid arthritis, bronchial asthma or some other immune disorders. This is a problem we face OPD. So with a very high postprandial and very controlled fasting, and of course in spite of their diet and lifestyle, it's very difficult to manage. Is there any take-home relief for this, sir?
Yes, sir. Obviously, this is a common scenario we come across. Whenever the patient is on steroid, the sugar levels go up very high. And many times what type of steroid patient is taking, we have to keep in mind. The second thing, if a patient is on morning dose of steroid, the peak hours of steroid happen in 6 to 8 hours. Most of the time postprandial sugar elevation happening in the post-lunch. So post-lunch only the sugar goes up very high, and that group of patients we have to either go with 30-70 insulin in the morning, or you can extra dose or booster dose in the pre-lunch hours to address that. So the patients on steroid, fasting will be reasonably good, as Professor Pandamas has said. Postprandial will be elevated and post-lunch will be quite high, and surprisingly the dinner time, the sugar pre-dinner and the post-dinner levels will come down. We know that hypothalamic pituitary axis. We know that we have to step up the steroid very lowerly and taper the dose very low, because high dose of steroid over a period of long time will alter the HPA axis. If a patient already on high dose of steroid on HPA axis, the morning surge of corticosteroids will not happen, particularly the nocturnal time will not happen. The chances of hypoglycemia in the early morning is quite high, those who are having steroid. So alteration of HPA axis is happening. So whenever patient is on steroid, as Professor Pandamas has said, look for post-lunch hyperglycemia. That is the time we have to address, and the nocturnal we have to reduce the dose to avoid early morning hypoglycemia.
So many a time we see a report patient, you treat lifestyle modification along with strict dosage of sulfonylurea, everything. say the patient comes with 300, 400, and then after 2 months you bring down the blood sugar levels to the acceptable levels. The patient invariably asks, can I reduce the dosage? Like that. Invariably, sometimes if you reduce the dosage, once again the blood sugar goes. So what will be your practical advice? These set of patients, when you give a set of drugs, the blood sugar comes to normal. Sometimes they say of hypoglycemia symptoms. Whether to stay the same drugs or to reduce the dosage.
Yes, sir. This is also very common clinical dilemmas in our clinical practice. With the good glycemic control, can we de-escalate the dose of oral hypoglycemic agents? We should keep in mind that the de-escalation, the common de-escalation point we should keep in mind is HbA1c. If HbA1c is less than 6.5, or if a patient is older age, 7 plus, 70 plus, 80 plus, if HbA1c is less than 7, whatever the target you fix, if less than that, we have to de-escalate the dose. And second thing, if a patient have hypoglycemia, with HbA1c 7.5 or 8, we have to assess the diet and history. Many a time pre-prandial hypoglycemia, pre-lunch hypoglycemia and pre-dinner hypoglycemia is quite high because patient skip the in-between mid-morning breakfast or mid-evening snack. That also be addressed for hypoglycemia. And many a time patient take tablets whenever they are sick. They tend to miss normal days. They take very strictly whenever they are sick, whenever they feel fever, whenever they feel diarrhea, vomiting, they take the tablet. That time they go for hypoglycemia. So any patient's hypoglycemia, look for the cause. If you treat the cause, it's fine. If there is no precipitating cause, despite patient developing hypoglycemia, with a good diet and good drug, we can de-escalate. Thank you, sir.
One minute.
Yes, sir. Yes, sir.
Should we wean away the statins or how do you do that, sir?
Yes, sir. Statin increases hyperglycemia is known fact, but it will not induce hyperglycemia. It may cause some after the this is
it gets uncontrolled.
rosuvastatin trial, Jupiter trial, we know that statin will increase hyperglycemia, and already a non-diabetic on medications, elevating 10 milligrams, 20 milligrams doesn't harm. But we are preventing cardiovascular events. 50% reduction of cardiovascular event. Patient will not die of hyperglycemia, sugar levels, inducing sugar. Patient will die of cardiovascular disease. So even in pre-diabetic, if you have a hypercholesterolemia, we do advocate statins. We know that pre-diabetic may end up in diabetic. But statin will delay the atherosclerotic disease. They prevents a heart attack by 50%. Patient will die of heart disease, not because of hyperglycemia to pre-diabetic to diabetic range. So statin we have to follow. No need to stop statin.
Should we lessen the dosage?
No need, sir.
Yes, sorry, Shanbham. With reference to your question, doctor,
Dehydration.
Dehydration, that also activates sympathetic nervous system, RAS system. Number one, if it is due to some pathological condition like sepsis, that can also result in increased release of cytokines, chemokines, that can also interfere with insulin secretion as well as insulin action 1. Regarding the steroids, of course, it depends upon the pharmacokinetic and glucodynamic profile of the particular steroids we give. And we have RSSDA guidelines for the management of steroid and hyperglycemia while managing patient with the type 2 diabetes. Recently, I have also published an article in JAPI, that is last month. I request all our delegates to go through. It is published in JAPI. And simple regimen is, if a patient is on Visolon 5 milligram, it peaks glucodynamic effect by around 2.5 hours. If you prescribe glyclazide 40 milligram, that also peaks the glucose lowering effect by 2.5 hours. So for every 5 milligram of Visolon, we can give 40 milligram of glyclazide. If it is administered once daily, give 40 milligram once daily. If it is given twice daily, give 40 milligram twice daily. One. Second thing is, if a patient is on twice daily steroids, it peaks around 2.5 hours. So NPH is the preferred insulin of choice because it peaks around 2.5 hours. So it more or less matches the glucodynamic effect mediated by the steroids and the glucose lowering effect mediated by NPH.
That's true, sir. Whenever patient on steroid, go with, as sir said, go with the premix insulin which have NPH, or go with simple NPH if you don't want postprandial glycemic control.
Thank you, sir.
In CKD, sir, CKD when they have CKD,
Yes.
when they have restricted fluid level of intake, sir, only 1 liter, 1.5 liters per day. In such cases, how will you manage, sir?
That patients will not have a developed dehydration, madam, because of water restriction. CKD and cardiac failure, the water, already they are water overloaded. So by restricting water, they will not develop dehydration.
Okay, thank
How
you.
steroid increases the blood sugar. It
How steroid
increases the insulin resistance, and then the blood sugar goes up.
Yes, sir.
So the reasonable answer will be, you decrease the insulin resistance by drugs, then the blood sugar will come down. That will be the reasonable
Sir, steroid
way of
not only
treatment.
increases insulin resistance, but it also induces glycogenolysis, it also induces gluconeogenesis, it forms new glucose and also alters the glucose receptor levels, insulin receptor levels. It addresses the IRS complex, will alters the IRS complex. So it not only insulin resistance, it also increases the glucose level by increasing the hepatic glucose output. So we have to go with some other medications. This is only short course. By within a short time period of time, we can't address the insulin resistance. The weight loss, all these techniques, it takes time to bring down the insulin resistance. Sir.
So you give the drugs which will reduce the insulin resistance. So for example, metformin or pioglitazone, that will be more reasonable.
Metformin will have already metformin will not sufficient enough. And the pioglitazone is a PPR gamma agonist. It takes at least 3 to 4 weeks to respond. So it has to work on the PPR gamma agonist in the nucleus. It has to transcript a protein. It takes 3 weeks to 4 weeks to respond. So for acute dose of steroid, short course of steroid, the pioglitazone will not be sufficient enough, sir.
Okay, sir, thank you so much. Unfortunately, we have to conclude this academic session. Moving ahead, we will be hearing some clinical insights on the approach to MASLD by Dr. P. Piramanayagam. We welcome you, sir.
Dr. P. Piramanayagam, sir, he is a consultant and medical gastroenterologist. His special interest include endoscopy, ultrasound, ERCP, enteroepic, endoscopy and GI multi. Sir, we welcoming you.
Good afternoon. Thank you so much for giving me this opportunity to be in this August meeting. I have been hearing the last 2 lectures and I have learned a lot hearing something non-gastro. I think the topic for today is clinical approach to MSLD. It was called as a non-alcoholic fatty liver disease till a few years back. Now the terminology has changed to metabolic dysfunction associated fatty liver disease. So I'll go through this in the next 20 minutes that has been allotted to me. I'll tell you about what is this new name, that why is the change in the terminology, what is this metabolic dysfunction associated fatty liver disease, what is the burden of fatty liver in India, and why is it important to identify this and risk stratify patients with fatty liver, particularly among diabetics, and what is new in the treatment for this fatty liver disease. So we'll start off with the thing. Normally, liver contains about 5% of its mass contains fat. So you'll have about 5% of the entire mass of the liver content is about in fat. So fatty liver, if it is more than 5% of the liver mass, we call it, if it accumulates more than 5% of fat in the liver, it's called as fatty liver. It could be in the under the microscope, it could be macrovesicular or microvesicular. And there are certain causes for macrovesicular and microvesicular pattern of things. Common things, of course, are alcohol and diabetes and obesity. Initially, about a couple of years back, we used to hear of non-alcoholic fatty liver disease. That is when you have a fatty liver by any imaging, like an ultrasound, along with no significant alcohol consumption. The problem was here. What was significant alcohol consumption, right? So many of the associations will say more than 30 grams a day for males and less than 20 grams a day for females was considered non-significant alcohol intake, and no other alternate causes of steatosis. So this was the broad definition with which we used the term non-alcoholic fatty liver disease. But quite often in clinical practice, you do find people taking alcohol in moderate amounts. They also have diabetes, they also have obesity, but what to term them as? They don't fit in with typical alcoholic liver disease going by the definition, and you can't term them as non-alcoholic fatty liver disease either. So that was what the problem arose, and then they decided, okay, we'll have an umbrella term called as metabolic dysfunction associated fatty liver disease, in which if a presence of another alternate cause for steatosis like alcohol or something else does not exclude them. Initially, a non-alcoholic fatty liver means you had to exclude significant alcohol intake. So when you use a term metabolic dysfunction associated fatty liver disease, the patient can still be on alcohol, they could be on some other drugs which could cause this fatty liver, apart from diabetes or obesity, whatever is a common reason for this. So what is this? I mean, though most of the literature till now, because this new terminology has come up in the last 2-3 years. So, but whatever we understand of the disease called fatty liver, it will still come up with the term of non-alcoholic steatohepatitis, because most of the literature still exists in that name. So what is the stages in which it undergoes? A normal liver, initially, whatever the insult, it starts like diabetes or obesity, it starts having a fatty liver, fat accumulates in the liver, and subsequently, in some people, there is also an ongoing increased inflammatory cytokine activation, increased macrophage activation, production of inflammatory cytokines, and the liver cells, instead of only accumulating vesicular droplets of fat, also shows inflammatory changes. So it causes hepatocyte ballooning, and there's some amount of neutrophil infiltration into the portal tract and surrounding the hepatocytes. So that is the state where we call as a steatohepatitis. It is not just accumulation of fat, you also have liver fat as well as inflammation. Subsequent to inflammation, the normal body's response is to heal, and healing is by accumulation of collagen tissue or the scar tissue, and that leads to remodeling. So that's the way it progresses. So you have accumulation of fat. The second hit is onset of an inflammation, followed by a repair mechanism where it leads to fibrosis and cirrhosis. The term non-alcoholic steatosis is about 40 years old. It was described in Mayo in a liver biopsy-based study with 20 non-alcoholic patients, no alcohol intake, but all their pathology was looking like patients who have an alcoholic hepatitis. So that is the way the initial thing is, they termed it as non-alcoholic steatohepatitis. On the right is a normal liver where you see normal hepatocytes. In the middle you see some amount of fat being accumulated. Here you see fat as well as the liver swells which are getting swollen, as well as some inflammatory infiltrate like neutrophils which are coming in. That is a NASH process. But what happens? I mean, how frequent or how common is this in India? So India seems to be somewhere in the middle. If you look at the United States or the Middle East, you seem to have a very high prevalence of non-alcoholic fatty liver, more than 40%. India is somewhere in the orange, somewhere around 30%. So estimated pool prevalence is about 1/3 of people in India tend to have fatty liver, either more so on hospital-based data. But what is also worrying is that among children also it's about 1/3, and that's a worrying sign. So in the study, I mean, in conclusion, almost across India you will find that people have about 30% of people having fatty liver, and 1 in 3 adults or children have fatty liver disease in India. So what is the proposed diagnostic criteria for this term of MSLD? Presence of hepatic steatosis by either imaging techniques like ultrasound, MR, CT, whatever, where you find some fat in the liver. If the patient is overweight or obese, or if he has diabetes, that is good enough to give the term metabolic dysfunction associated fatty liver disease. But if he is of normal weight, he is not diabetic, then there should be 2 of these 7 criteria should be filled, which is a marker for metabolic dysfunction. It could be increased waist circumference, high blood pressure, high triglycerides, low HDL, could be pre-diabetic, or a HOMA level high or a high CRP level. So if 2 of the 7 are present, then you can term it as metabolic dysfunction associated fatty liver disease. So the patient can have alcohol, can have some other reason for fatty liver also, but they won't be excluded from the study. But why should we know about this fatty liver disease? What is the natural history? How do they go about? See, almost you will find that 25% of patients will progress from a simple fatty liver to a status of inflammatory, that is NASH. And of these, one in each stage, I mean from NASH to fibrosis, about 20% still progress. But what is also worrying is, apart from patients who are cirrhotic, who progress to develop hepatocellular cancer, some people with steatosis, just plain fatty liver, can also progress to HCC. Though the proportion is very small, but still we do find that particularly in Asia, about 1/3 of people with HCC do not have cirrhosis. They don't have hepatitis B. They just seem to have some fatty liver, but they seem to develop HCC as well. So that's the worry. Not only liver related, if you look at this population cohort study from Sweden, they find that the all-cause mortality seems to be higher in patients with fatty liver disease compared to a normal general population. And more importantly, it seems to be matching with the increasing progression of cirrhosis. Only fatty liver, NASH, as well as fibrosis and cirrhosis, the all-cause mortality seems to be going up. Why is this so? Initially, we thought that fatty liver was associated and the cause of mortality was due to the metabolic dysfunction and cardiovascular mortality alone. So that was what was thought of. But these studies seems to say, show that it is not just cardiovascular mortality alone. There seems to be increased risk of extrahepatic cancers which are coming up and cirrhosis specific mortality. Who are these patients who develop this kind of specific one? The most common cause of mortality in patients without advanced fibrosis still seems to be cardiovascular. But if the patients develop advanced fibrosis, the death seems to be from liver disease. So we have to identify patients who are at higher risk of progression, particularly to the advanced fibrosis. So how do we risk stratify patients? I mean, in clinical practice, I'm sure about 70% of diabetes, type 2 diabetes in India, Indian data says that about 70% of them have fatty liver. So you're going to have an ultrasound in 70% of your patients who will say that there is fatty liver. But do they all progress? Can we identify patients who are at high risk of progression to liver disease? That is where the question comes. So there are some risk stratification scores. I'll start with a small case scenario here. Shortly, 3 minutes more. Okay, so there's a 46-year-old gentleman, diabetic, dyslipidemic for 10 years. He's been on metformin, glimepiride and atorvastatin. He also has some ethanol intake. He's obese. On clinical examination, you find a hepatomegaly. It's a grade 2 fatty liver. Counts are good, mild rise in liver enzymes, triglycerides are high. And you find that, this is a clinical diagnosis you'll make, diabetes, obesity with metabolic dysfunction associated fatty liver disease. Gold standard would be a liver biopsy, which tells us that there is significant fibrosis, but not every patient is going to agree for a liver biopsy. So non-invasive modalities are two ways. One is a blood test, the other is a imaging modality like a fibroscan or an MR elastography. But how do we go about? The simple test that you can do at your clinic is called as a FIB-4 score. That includes only age. You need only 4 parameters: age, ALT, AST, and the platelet count. So there's an online calculator which if you feed in, for this patient I've just fed in, it comes up with a point of 2.46 points. Anything less than 1.3 FIB-4 score, the risk of significant fibrosis in the liver is going to be very minimal. You can just keep them on follow-up, tell them not to worry. You can come back and reassess in 3 years' time. But anything above 1.3 to 2.6, that is indeterminate. More than 2.6 is a very high risk of advanced fibrosis. So anything above 1.6, you're going to ask them to refer for more imaging or to a higher center where you can look for the amount of fatty liver by two tests. One that is called as a fibroscan or a transient elastography, where you send some acoustic waves from the liver. It's like an ultrasound, which sends the shear waves, and then you can read it back, and if it is a very firm or hard liver, the velocity with which the shear waves go up and down is going to be quicker. So depending on the velocity with which travels, you get your kilopascal measures. And for a NASH, you will see that anything above 14 is considered to be significant fibrosis. We are interested in picking up patients who are having significant fibrosis. When I say significant, we are looking at F3 and F4. F2, F1 is considered not so significant or advanced fibrosis. So this fibroscan is one way of looking at it. Other is more sophisticated way or much more accurate way is to look at MR elastography, and that can also give you liver stiffness measurement and the S measurement, and then you can correlate to the stage of cirrhosis. Apart from that, you do have some proprietary serum biomarkers which are not easily available. One of the private labs does do a fibro test, but pretty costly. So in practical terms, you do a FIB-4 score in your clinic. If they have a FIB-4 score more than 1.3, suggest a fibroscan, see if they are F3 or F4. If they are F3 and F4, then they are at significant risk of developing liver fibrosis. So this is what the ASLD guidelines tell you. Identify patients at risk, take a history and labs, do a FIB-4 score. If they are indeterminate, like 1.3 and above, ask for further imaging with a liver stiffness measurement. If they are high, refer to a hepatologist. But what happens? So this gentleman had a FIB-4 score of 2.4. We did a fibroscan. It is 16 kilopascals. So he has a advanced fibrosis. He is completely asymptomatic. I mean, he doesn't have any liver-related symptoms, but there is significant fibrosis which is still already going on. And these patients, apart from their cardiovascular mortality, they run a high risk of developing liver-related complications. So that is something that we need to monitor. So how do you treat these patients? I mean, is there anything new that has come up, or it is just standard diabetes treatment? So weight loss, of course, exercise, and I'll come to the pharmacotherapy. Since we are running out of time, I'll just run it through. Weight loss of more than 10% improves the fibrosis, but only less than 10% of people are able to achieve a good weight loss. So we have to look at beyond, of course, dietary changes, avoid saturated fat, refined sugar and sugar sweeteners. It seems that coffee consumption of up to 3 cups per day seems to be having some effect on fibrosis. So all of those who are coffee lovers, I think this is something that you can possibly advise. Improvement in physical activity, what is suggested is at least 150 minutes of exercise. Brisk aerobic exercise should be good. That will help achieving some reversal of fat in the liver. Apart from the direct weight loss, we should encourage them to anyway go ahead with the exercise even if they don't lose weight, because their metabolic these things will be good, will change. There are multiple medicines which have been tried to see specific liver-related changes. We do attempt at vitamin E, which seems to improve the liver biochemistry, but does not seem to have improved the steatosis or the inflammation that goes on. Pioglitazone is soon to have some improvement in the liver inflammation, but the side effects have essentially ruled it out that we don't use it often. Metformin, no significant change in the NASH. SGLT2 inhibitors, very good. I just heard that they are good for cardiovascular adrenoprotective effect, but still we don't have much data for liver fibrosis or reversal of liver cirrhosis. There are studies going on, but as of now it has not been proven. UDCA we all generally use if the liver enzymes are high. It seems to improve the biochemistry, but again at the pathological level it doesn't seem to improve any scores. Saroglitazar is a very interesting molecule. I think most of you will be using more than I do. This is one of the first DGCI approved drug for non-alcoholic steatohepatitis to be used particularly in patients with diabetic dyslipidemia with fatty liver. It seems to improve the inflammatory score, but there are more data is required whether it improves the liver fibrosis or not. So we don't have published data yet in this regard. Obeticholic acid, FXR agonists, it's mainly FDA approved for primary biliary cirrhosis, not for fatty liver, but it seems to improve the fibrosis score, though it is not FDA approved asset. 3 drugs which are very promising. One has already been approved. 1 year earlier, I would say there was no FDA approved drug for NASH, but now we have one drug called as resmetirom. It's a thyroid hormone receptor beta agonist. It has been FDA approved, shown that in patients with advanced fibrosis, 25% improvement. 1 in 4 seem to have improvement in fibrosis score, which is a big thing in hepatology. This is already approved. There are 2 more drugs which are in phase 2 trials which seem to have, one is a tirzepatide and another is a survodutide, GLP-1 agonists, another is a glucagon receptor and GLP-1 agonist. Both have shown to have improvement in the fibrosis score also. So if we have a phase 3 trial which is coming up, probably in the next few years you will have 2 more drugs if they show improvement. So tirzepatide I believe has been recently approved for diabetic use in India also. So you'll be going to. So in this patient, treatment plan will be, of course, avoid alcohol, dietary modification, suggest exercise plan, 30 minutes at least brisk walk per day, so 150 minutes roughly per week. Pharmacotherapy, apart from this usual diabetic drugs, you can consider adding, if it is available, tirzepatide or maybe a semaglutide for glycemic control in addition to losing weight, apart from direct effect on the fatty liver disease also. You can consider adding a saroglitazar for controlling the hypertriglyceridemia and seems to improve some inflammatory changes for the fatty liver. Resmetirom, if it is available, it's pretty costly and it is right now not available in India. Of course, you will obviously modify the cardiovascular risk, and we have to keep an eye on extrahepatic cancers which are coming up. So the age-appropriate screening for extrahepatic malignancies also. So that I'll just summarize again. Go for FIB-4 score. If it is more than 1.3, look for liver stiffness, identify patients who are at high risk for liver-related complications, and now we have a new drug which is coming up, which is resmetirom, and some other anti-diabetic drugs in the near future. Thank you so much for your time. I'm sorry for taking a little more of the allotted time.
Thank you, sir. Thank you so much.
Siddhi Vinayaka Sharanu Vidya Pradayaka Sharanu Siddhi Vinayaka शरणु विद्यप्रदायका शरणु पार्वती तनयमूरुति शरणु मूषिक वाहना शरणु पार्वती तनयमूरुति शरणु मूषिक वाहना शरणु सिद्धिविनायका नितिलनेत्रन देवी सुतने नागभूषण प्रियने नितिलनेत्रन देवी सुतने नागभूषण प्रियने तटिल तांकिट कोमलांगने कर्णकुंडल धारणे तटिल तांकिट कोमलांगने कर्णकुंडल धारणे शरणु सिद्धिविनायका कुक्षिमहालम्बोदरने इक्षुचापनकेलितने कुक्षिमहालम्बोदरने इक्षुचापनकेलितने पक्षिवाहन श्रीपुरन्दर विठलना निज दासने पक्षिवाहन श्रीपुरन्दर विठलना निज दासने शरणु सिद्धिविनायका शरणु विद्यप्रदायका शरणु पार्वती तनयमूरुति शरणु मूषिक वाहना शरणु सिद्धिविनायका शारदे करुणानिधे सकलानवाम्ब सदा जना चारणादिमगीतवैभवपूरिता किल दीप्तते शारदे करुणानिधे सकलानवाम्ब सदा जना
Please remain standing as we'll hear the Tamil Thai Valtu. You may all be seated. Thank you so much. Now we will formally launch the event with the lighting of the lamp. I request the dignitaries and the honored members of DClub to kindly make it to the dais. Thank you so much. As we conclude the inauguration ceremony, I humbly request the audience to rise as we sing the national anthem as per tradition. Thank you. Please be seated. With that, we are now going to have the Professor Dr. V.T. Balaraman oration delivered to us by our chief guest, Dr. Shanmugavel. I request our organizing chairman, Professor Dr. P. Paranthaman, to introduce us to the speaker.
Very good afternoon, everybody. It is my pleasure and honor to read out the citation of the orator, the eminent physician, diabetologist, Dr. N. Shanmugavel. The DClub and the organizing committee of DCCon 2024 has immense pleasure in honoring the eminent physician and diabetologist, Dr. M. Shanmugavelu is MD, FICP, FRCP Glasgow and UK and Fellow of Royal College RSDI. A specialist in internal medicine and diabetology, is a chairman Trichy Diabetic Specialty Center. For delivering the most prestigious Professor V.T. Balaraman oration. The talk oration is Inter-Organ Metabolic Crosstalk in Diabetes Mellitus. On Saturday, 13 July 2024 at Ramada Plaza, Gindi, Chennai. Dr. M. Shanmugavelu is graduated in the year 1980, MD Internal Medicine in the year 1985 from Government Kilpauk Medical College, Chennai. He received fellowship of FRCP Glasgow, UK in the year 2015. FICP, that is Indian College of Physicians, in the year 2016. RSDI Fellowship Award in the year 2020. He has been served the Tamil Nadu Medical Government Service during the year 1981 to 1992. And he has a best academic member, active member, both state as well as national RSDI. He is a past secretary of RSDI Tamil Nadu chapter and he has been the regional faculty for Public Health Foundation of India and Delhi from 2010 till date. He has published more than 50 articles in both national and international reputed journals and for his excellence. He was honored with Professor M. Sam G.P. Oration Award in DCCon 2017 at Madurai. Economic Times Inspiring Diabetologist of the India Award at Delhi in the year 2018. Dr. Arul Raj Guest Lecture Award in Tapicon 2018 at Kodaikanal. Dr. M.S. Ashraf, Doctor's Day Award in IMA Trichy branch, and RSDI UP State Chapter UPCon 2024 RSDI Commemorating Oration Award was given for his excellence. Dr. Meenakshi Sundaram Shanmukhavelu is a principal investigator for many trials, primary trials and both phase 4 and phase 3 trials, especially SRID, insulin degludec plus, and HOPE-D trial, a TICOS trial, and TICOS trial, and so many landmark trials. He was a principal investigator for epidemiological studies of solid and in-depth insight, etc. DClub and the organizing committee of DCCon 2020 is pleased to present this most prestigious Professor V.T. Balraman Oration Award to Dr. Meenakshi Sundaram Shanmukhavelu for recognition of his meritorious service in the field of diabetology. Thank you, sir.
This one for advance. Right. Senior doctors, my doctor friends, and of course former friends, I feel extremely happy, honored, and most privileged to have been invited to deliver Professor Dr. V.T. Balaraman's Oration Award. I may fail in my duty if I do not thank all the organizing committee members of DClub Con 2024. Can I have the slide? So DCCon 2024, Professor V.T. Balraman's Oration. My tribute to Professor Dr. V.T. Balraman. Professor V.T. Balraman, an esteemed honorary professor of medicine at Madras Medical College, has established a distinguished reputation within the medical industry, specializing in tropical medicine and diabetes. He enjoyed a successful career over 4 decades at Madras Medical College, where he once oversaw the Department of Diabetes at MMC and garnered great acclaim for his exceptional skills at a young age. His gentle demeanor, generosity towards deserving students, and unwavering commitment to ethical practice have earned him the loyalty and affection of his patients, colleagues, friends, and family. Beyond his medical pursuits, Professor V.T. Balraman is revered for his eloquence in Tamil and English, captivating audiences with his extemporaneous speeches in a deep, resonant voice. His remarkable memory to recall names and phone numbers, his love for fine cuisine, music, Tamil literature, and speeches of Thiru Kripananda Warrior are just a few traits that set him apart. Influenced by esteemed mentors like Ayya, Professor Dr. Ratanavel Subramaniam, I don't know how many of you remember Professor Dr. R.S. Ratanavel Subramaniam, Professor Dr. Samjeev Moses, Professor Dr. M.S. Amarasan, cardiologist Professor Dr. Sankaran, and Professor Dr. V. Sachaya, as well as close friends. Professor V.T. Balraman has emerged as a true role model, embodying respect, inspiration, integrity in all his interactions. Professor Dr. V.T. Balraman's passion for his profession is evident in his close association with his patients, peers, and students, always offering words of kindness and hospitality over the years. His legacy as a dedicated physician and a compassionate human being will be forever cherished by those fortunate enough to have crossed paths with him. In fact, I did my senior house agency under Professor Dr. M. Thayamanavan I happened to interact with V.T. Balaraman during the time, whenever he made rounds in intensive medical care. Not only that, when I did my 4th MBBS in 1977, there was an exhibition organized by Professor Dr. B. Kizar Ahmed. That is the exhibition for the patient with the diabetes. At the time, Dr. Sam G.P. Moses, Kizar Ahmed, U. Muhammad, and Dr. V.T. Balaraman, they were standing. I asked Dr. V.T. Balaraman and Sam G.P. Moses one question. Sir, can we give insulin in the night time to patients with type 2 diabetes? He said, why not? Sir, night time we never give any meal after 9 o'clock. The chances of risk of hypoglycemia will be more if we give, and we need to monitor very closely. He said, when the indications are compelled, you are supposed to give. Second time, there was a program organized in World University Service, Chetpet, in the year 1980 or 79. They collected a registration fee of rupees 10. In fact, that conference was supported by, I think, Pfizer, next is USP, Alembic, and Kext, not Aventis as of now, Kext. They were the real pharma industry marketing the products for the management of type 2 diabetes. That is dianyl, racetinone, alkamide, next is cadila also, chlorphormine. That time, the concept of diabetic WBC, platelets, coagulation profile changes, fibrinolytic system was introduced. Along with that, they brought the role of yoga at that time. I stood up and asked Dr. V.T. Balaraman, if a normal man does yoga, what will be the chance of developing he or him hypoglycemia? He said, no. Patient with diabetes, when they do yoga, definitely they will get, it will offer them very improvement with reference to glycemic control. These are all my questions with reference to V.T. Balaraman, and my sincere thanks to my friend Dr. Dhanamitran, Professor Dr. Parandaman, Dr. Natarajan, Dr. Jaykumar, and U.V. Mohan for inviting me and also honoring me in this august presence. So, inter-organ metabolic crosstalk in diabetes with a particular focus on evidence-based findings, and of course, I thank every members of this particular organizing committee and my disclosures. So what I'm going to do for another 20 minutes, the contents of my talk line includes introduction, background, inter-organ crosstalk under physiological conditions, next is inter-organ crosstalk in MED syndrome, and the causes for beta cell dysfunction, of course, conclusion. So in order to maintain homeostasis, adapt to external conditions, the different tissues of multicellular organisms communicate with each other via multiple signals. Peripheral organs, they produce a plethora of bioactive molecules, including hormones, that ensure intercellular signaling in an autocrine, paracrine, or endocrine manner. Peripheral organs and immune cells produce cytokines that also participate in inter-organ communication. Nervous system coordinates not only by the production of neurohormones, but also by direct invasion of the target tissues. Sympathetic, parasympathetic fibers, they express enzymes for the biosynthesis and transport of specific molecules like neurotransmitters and neuropeptides. Claude Bernard suggested that system involving chemical messenger ensures a communication between the different organs of the body. The term hormone was first used in 1905 by the British physiologist Ernest Starling to describe the gut hormone secretin that is first described just 3 years prior. Pancreatic insulin and glucagon were successfully identified, synthesized, and used for therapy in the course of 20th century. The identification of signaling molecules like hepatokines, myokines, adipokines, beta-kines to describe the hormones produced by liver, muscle, white adipose tissue, and brown adipose tissue respectively. Signaling molecules, they respond to fasting feeding cycles, circadian rhythm, cold exposure and exercise, thus participating in organism's adaptive response and ensuring metabolic flexibility. So inter-organ communication that is altered in different pathological conditions like obesity. So pharmacological interventions to modify the production of hormones, cytokines, or directly delivering recombinant hormones or cytokines are being explored as promising approaches to treat a variety of obesity-related endocrine diseases. So inter-organ crosstalk under physiological conditions. So under feeding conditions. So food ingestion stimulates the secretion of gut hormones. We have the GLP, secretin, LEAP, insulin, leptin, fibroblast growth factor 19, right. These GLP and secretin stimulate insulin, reduce glucagon secretion. Fibroblast growth factor reduces bile acid synthesis. Leptin acts in the CNS to repress food intake. Overall, these gut hormone signals to the brain to reduce food intake. Under fasting conditions, so fasting stimulates the secretion of various hormones. So we have ghrelin, glucagon, FGF21, adiponectin, asparagine. So ghrelin targets the brain to increase food intake, increases glucagon secretion. Glucagon increases hepatic glucose production and induces lipolysis. And FGF1 increases lipolysis. Asparagine and adiponectin decrease energy expenditure and promote food intake. Next is under cold exposure, inter-organ communication. So cold stimuli sensed by the neurons in the skin, they activate the thermoregulatory hypothalamic regions of the brain. So we have the orexin, next is bone morphogenetic protein 8, next is sympathetic nervous system, next is thyroid stimulating hormone. Sympathetic nervous system stimulates norepinephrine secretion. Hypothalamic pituitary axis, they contribute to the activation of bad thermogenesis. Muscle shivering promotes release of irisin that in turn causes thermogenesis. So fibroblast growth factor 21 and bile acid secretion contribute to the browning of fat. Next is during exercise. Aerobic exercise or strength training trigger the secretion of numerous myokines. We have interleukin 6 that mediates muscle glucose uptake, insulin sensitivity, insulin production, hepatic glucose production, ensuring the availability of energy substrates. Irisin triggers the remodeling of white. So white adipose tissue becomes brown and therefore it gets involved in thermogenesis. It increases muscle oxidative metabolism as well as reduces hepatic glucose output. FGF21 reduces muscle insulin resistance. Overall, physical exercise promotes browning of fat and bad thermogenesis to meet the increased demand for fatty acid and glucose oxidation. Communication from the gastrointestinal system to pancreatic islets, we get the incretin, serotonin, ghrelin. These hormones play an important role in the regulation of nutrient uptake and storage. So they modify energy metabolism and also have diverse metabolic effects on target organs. So communication from the gastrointestinal system to the central nervous system. We have the GLP. So the signals are transmitted via the vagus to the nucleus tractus solitarius or the area postrema, and several portions of the brain, they express the glucose GLP-1 subcharts, including the arcuate nucleus in the hypothalamus. In turn, GLP activates the POMC-COT neurons, and at the same time inhibiting the neuropeptide by agouti-related peptide neuron, and the whole signal result in satiety or reduced food intake. So the effect mediated by GLP-1, GIP, we know the important with reference to GIP is it increases adipose tissue insulin sensitivity. We have the glucagon that increases glucose production, satiety, energy expenditure, promote weight loss, improvement in glycemic control, decreases liver fat as told by our gastroenterologist. So the clinically most relevant mechanism of action of GLP-1, GIP, glucagon with reference to insulin secretion, glucagon suppression, weight loss, energy expenditure. So the evolving GIP and GLP partnership in metabolism. We have the effects mediated by GLP, effects mediated by GIP, combined GLP and GIP with reference to food intake, weight loss as well as insulin secretion. We have the unimolecular monoagonists like liraglutide, exenatide, dulaglutide. Combining GIP, GLP, we have the twin cretins, that is unimolecular co-agonist. And we have the two components, they bind with the respective receptors that is present in the different targets or the tissues, ultimately potentiating insulin secretion, improves glucose tolerance and result in significant body reductions. So we have the mono, dual and triple agonism, exenatide, lixisenatide, and we have the liraglutide as monoagonist. That is mainly, that is promoting insulinotropic and insulin sensitizing property of GIP, anorexic effects of GLP-1, thermogenic and lipolytic effects of the glucagon. Combining GIP, GLP-1, we have the tirzepatide. Combining GLP and glucagon, we have the cotatutide. Combining all the three, we have the retatrutide. So communication from the gastrointestinal system, gut microbiota associated signaling molecules. So gut microbiota convert environmental signals and dietary molecules into signaling metabolites. So we have these short chain fatty acids, bile acids, branched chain amino acids, and of course the lipopolysaccharide. These gut microbiota are associated bioactive compounds. They can signal to different organs and tissues in the host to modulate the function of these organs and tissues. So the microbiota influence on glucose homeostasis with reference to GLP, with reference to gluconeogenesis, also improving insulin sensitivity or inducing insulin resistance. In the presence of inflammation, the lipopolysaccharide level goes up. It alters the mucosal permeability, causing bacterial translocation and metabolic endotoxemia. Bile acids play an important role with reference to glucose metabolism through primary and secondary bile acid metabolites. So flow charts representing the effect of diet pattern on bacterial population. So diet rich in plant material that results in improvement in gut mobility, insulin sensitivity, thereby making the gut non-leaky. Animal product that causes reverse effect, induces insulin resistance, inflammation, and make the gut leaky. So the main mechanism between gut microbiota and type 2, very important thing is they maintain the intestinal mucosal barrier, intestinal epithelial integrity, and also glucose metabolism. So gut microbiota alters host homeostasis through production of metabolites, activation of inflammatory cascades, disrupting the permeability of the intestinal mucosal barrier, and direct signaling action through incretin system. So the bariatric surgery, yet another communication from gastrointestinal system to pancreatic islet. So immediate impact of surgery is caloric restriction and enhanced nutrient and bile delivery to the mid-distal jejunum and ileum. And these are all the potential mediators. Alteration with reference to bile acid signaling, microbiome, gut hormones, neural signaling, intestinal adaptation, reduced hepatic and pancreatic triglycerides, improvement with reference to the glycemic status. So communication from liver to pancreatic islets, we have the liver-derived factors, hepatokines. These hepatokines, lipids, and other small molecules, they have diverse effect on target organs, including adipose tissues, brain, and cardiovascular system. Next is the communication from adipose tissue to pancreatic islets, adipose tissue derived factors. We have the adipokines, secreted molecules signal to brain to regulate energy metabolism, and others including adipokines and lipokines, they have diverse effects on their target organs. Next is from muscles to beta cell. Skeletal muscles is the largest organ, major site of insulin and exercise mediated glucose disposal. So we have the interleukin that is produced by skeletal muscles during exercise. It promotes GLP-1 secretion. It also improves beta cell function, not only beta cell function but also improves insulin sensitivity. Next is from nerve cells to pancreatic islets crosstalk. Pancreatic islets are innervated by parasympathetic and sympathetic nervous system. In hyperglycemia, the parasympathetic nerve release acetylcholine, that in turn potentiate insulin secretion. And we have the other parasympathetic nerves also release other peptides like vasoactive intestinal peptide and gastrin-related peptide and so on. In contrast to hyperglycemia induced activation, hypoglycemia, it stimulates the sympathetic nervous system, induces glucagon secretion. If you look into the postprandial glucagon secretion, it is influenced by the nutrient and also partly regulated by the parasympathetic input. Next is bone to beta cell crosstalk. Bone is again considered as an endocrine organ. Osteoblast specific secreted molecule osteocalcin enhances insulin secretion, improves insulin sensitivity as well as energy expenditure. Insulin signaling in osteoblast, it facilitates bone resorption. So there is an interplay between beta cells, osteoblast as well as osteoclast that regulates beta cell function as well as whole body glucose metabolism. So inter-organ crosstalk in MET syndrome. VAT, white adipose tissue, accounts for more than 50%. Patient with obesity, they exhibit high plasma levels of leptin. So hyperleptinemia, just like hyperinsulinemia. In addition to leptin level, there occurs leptin resistance. So the improvement what we see with reference to reduction in the food intake and increase in energy expenditure is not observed or not seen in the presence of hyperleptinemia and leptin resistance. And this pathologic leptin signaling also results in increased hepatic glucose output. Not only that, there is reduced thermogenic activation of bad as well as overall energy expenditure. And this circulating asparagine also induces hyperglycemia by inducing insulin resistance. These are all the alterations